We're very, very fortunate to have Dr. Kollef here, one of our excellent critical care attendings. Here's our disclosure slide. Sadly, I have nothing to disclose. You can see Dr. Kollef up there. So we're going to get into our case. So our case is of a 27-year-old female, past medical history of obesity and chronic cough, presenting with hemoptysis. Before we get started, we're going to go through the history of CPC. So we always like to remind us of kind of where this case comes from, or where this conference comes from. So CPC was originally modeled after the case discussions in the law school over at Harvard back in the late 1800s, was brought over to WashU in the early 20th century by the chair of medicine at the time, Dr. Dock, looking very friendly in this picture here. And you can see back in the 50s, an example of our CPC, and we're happy to keep doing this today. To go a little bit about our expert, so we have Dr. Kollef here. I'm going to speak on his behalf a little bit, but he can happily jump in if need be. So Dr. Kollef, I think many of us in the audience know him and have been fortunate to learn from him in the medical ICU. He's a Golman professor of medicine here, did his medical school at the University of Rochester School of Medicine in New York, residency at Madigan Army Medical Center in Tacoma, Washington, fellowship there as well in pulmonary and critical care medicine. Interestingly, I learned this just by literally Googling you, that you ran a medical ICU, or were the director of a medical ICU at an Army Medical Center in Colorado before coming to WashU in 1992. And we've been fortunate to have you here ever since. And 27-year-old history of obesity and chronic cough here with hemoptysis. We'll give you an HPI and then we'll get your thoughts. So you are seeing them in the pulmonary clinic. And Dr. Kollef did just say to me beforehand, they always give me a pulmonary case, even though I really just do critical care. So here we are. They're here in the pulmonary clinic. They're reporting hemoptysis for about 5 months. It's been varying from strings to cups of blood. It's never been particularly brisk or copious. Comes and goes for days to weeks at a time. The patient actually had like a full month with nearly daily bleeding and had a month with only a few days. Hasn't noticed any clear triggers. They also deny lightheadedness, dizziness, fevers or chills or weight loss. She does report some progressive dyspnea on exertion. It's been limiting some of the more exertional components of her job at a nursing facility. And then just to give you a little bit of background, so they do have this chronic non-productive cough since their teenage years. Doesn't really carry a formal pulmonary diagnosis. It seems like it's been bothersome, but not so much to, try inhalers or anything like that. So no formal diagnosis there.
Okay. I saw a patient like this once who ended up having a bronchial carcinoid and was having hemoptysis and had gained a lot of weight related to that and steroids. I mean, this was almost 42 years ago, but I'm sure it's not that. But, this is hemoptysis and it's not massive hemoptysis. I mean, what we deal with in the ICU is typically massive hemoptysis. And the main concern there is compromise of the airway. And so I'm not going to talk much about that because there are specific things that we need to do in order to protect those patients from asphyxia. And so that's not pertinent in this particular case. So this woman has non-massive hemoptysis, and it can be anywhere from just blood streaking to the coughing up of blood. Occasionally, they can even have more brisk bleeding, and then it tends to stop off. So the issue is, what could be causing hemoptysis in a 27-year-old woman who's obese and has had some shortness of breath over a period of time? I guess some of the things that I would ask about her history, has she always been obese?
Yes.
Okay, so she's always been on the heavy side. And is she married? Has she had children?
She is not married. She does live with her partner.
Children?
They have not tried to have children.
So they haven't tried to have children yet. Okay. And is she on any medications like birth control pills or, okay. So, if she were taking birth control pills, maybe you'd worry about chronic thromboembolic disease and someone like this who might be presenting with severe pulmonary hypertension and might have, hemoptysis on that basis, but that's probably not the case here. And, I probably want to get some more history in terms of other drug exposures. Does she use anything IV or smoking or no?
No, and we'll get into a social history in a little bit.
Okay, so she's not a drug user as far as we know. So right now, the differential diagnosis is pretty broad, and the main things that you worry about, at least for a patient like this in if you look at the patients globally in the world, hemoptysis presenting to a pulmonary clinic, it's going to be tuberculosis, it's going to be paragangliomyces, it's going to be some type of an infectious disorder, and then lung cancer. In the US, it's lung cancer. That's number one. But she doesn't have lung cancer. Presumably, it would be very rare for her to have a primary lung cancer, although they can occur in young women. But it's unlikely to be the case for her. It's unlikely that she'll have anything like TB or paragangliomyces or another chronic infection that can cause cystic changes and then cause disruption of the pulmonary vasculature leading to hemoptysis. So now we're thinking, does she have something that might be a little more chronic given her shortness of breath for a period of time? And there are some diseases, some of which occur more commonly in women. I actually had a clinic at one time when I was in the military and had a number of women with LAM. And actually, for the first year I was here in 1992, also had a clinic with 4 or 5 women that had LAM in it, as well as some patients with pulmonary alveolar proteinosis. And then I gave up pulmonary. So LAM is certainly something that's interesting here in this woman, primarily because she is a woman, she's having hemoptysis, she's had shortness of breath for a period of time. And obviously, we'll try to get some diagnostic imaging to see if that might be the case. But in terms of other history that might be available, other than her exposures, including PET exposures, I mean, it'd be extremely rare for her to have something like hypersensitivity pneumonitis from an exposure to a bird or something else that's resulting in chronic cystic lung disease that can cause hemoptysis. I think the next step is just to hear a little bit about her family history. Is there any family history of pulmonary fibrosis? Is there any exposure history? And go from there.
Okay. So a little bit of more HPI. This is just to sort of give you a background on this cough. So she actually did go to the ED not too long ago for symptoms a few months back. She got a CTA at that time that was negative for a PE. It had no pneumothorax and no consolidation. Did demonstrate some sub-centimeter central lobular ground glass nodularity and a left lower lobe ground glass opacity with a small left pleural effusion. She had an ED visit a few years back, and I'll say this ED visit and the prior one were both at outside hospitals where she had some shortness of breath. She was actually told she had a pneumo on a chest x-ray, and then had a repeat a little bit later and said it wasn't there anymore, and she was told it was a mistake. It's rather unclear what actually was going on here, and unfortunately we have no access to the images. To get into the heart of what you were asking about, so medical history, obesity and this chronic cough, nothing else exciting. No surgeries, no notable family history to speak of, including any pulmonary diseases. Has an allergy to red dye with some swelling, but no other notable allergies. Not on any medications. She's a never smoker and no other tobacco intake. She's a social drinker, no drug use, and then all the fun pulmonary questions, no birds, caves, hot tubs, fun dusts or travel. She lives down in the Cape. She does have 2 dogs and cats. Has had them for a while, and then works at this nursing facility, no chemical or dust exposures.
Okay, so really, I mean, this is helpful from the standpoint of just ruling some things out. It sounds like something like hypersensitivity pneumonitis would be less likely given her exposures. She also seems to have a more focal ground glass opacity in the lower lobe. I think it was on the left side. And then she's got some other ground glass opacities throughout her chest. So the issue is what could be going on given this history. And, I still think that something like LAM is a possibility if they misread the CT. So I'd want someone to look at the CT or maybe get some imaging on her to make sure that we're not missing that specific diagnosis. And the CT will help with that. If this is truly just ground glass infiltrates and it's primarily involving the left lower lobe, what could be accounting for that? It could be a form of ILD that she might have. And so, we might want to think about that and think about whether or not we want to get pulmonary function studies on her in addition to a high-res CT and potentially some serologies just to make sure that she doesn't have a collagen vascular disorder like rheumatoid arthritis, Sjogren's syndrome. She doesn't have mechanics hands, right? So, we would want to send off all the serologies in that particular case to work that up. With lower lobe involvement and hemoptysis, the other thing you worry about is, a sequestration. So, and we occasionally see those, even in the ICU, sometimes we'll see them. If she has a sequestration and has altered blood flow, sometimes, the primary blood flow to that sequestration may come off the aorta, or it could be a bronchial circulation. That could be accounting for hemoptysis, particularly if there's some recurrent inflammation or infection within that area. And then, the issue is, does she have some chronic infection? But this has been going on for years, and you wouldn't expect her to have an infection if it weren't cystic in nature. And most of the disorders that are infections that cause hemoptysis over the long term are cystic. Cystic disorders like tuberculosis, paragonnomyosis. If she had cystic fibrosis, that would be one thing. If she had bronchiectasis, but she doesn't have any of that, at least based on the initial CT report that we have. So I think at this point, I would probably think about getting pulmonary function studies on her, as well as a high resolution CT scan. I'd want to look at her chest X-ray first, and we could start with that. And then, go from there.
Okay, I'll give you a little bit more qualitative stuff too. So her ROS is here. I'm not going to read it all out, but we know about the pulmonary complaints. She does also report sort of a diffuse episodic abdominal pain. That's also been present for years. And then immune, she reports multiple URIs over the past few years. Kind of unclear if it's more of the same cough or actual new syndromes. Otherwise, nothing particularly exciting. And we'll give you...
The URIs are interesting because it suggests that she may be immune suppressed. So maybe she's got combined immune deficiency disorder. You'd probably want to check her quantitative immune globulins, make sure she's not lymphopenic. If she hasn't had an HIV, check an HIV on her. I think those are some things that would probably be worth pursuing given this history of recurrent urinary tract or upper respiratory tract infections. And we don't know if she's not been able to get pregnant at all. I mean, is she just having recurrent infections? That would be an unusual presentation for hemoptysis. I mean, she has to have something more focal and more chronic going on in her lung. And this it's not a vasculitis, or it shouldn't be a vasculitis, given that, she's having episodic hemoptysis. That would be really unusual, even for someone who had an ANCA-positive vasculitis to present with recurring hemoptysis over a prolonged period of time. So I'm not saying it's impossible, but it would be very unusual. So I still think at this point, pulmonary function studies, probably a high-res CT after looking at her chest X-ray, and then going from there.
Yeah, sounds good. We will get there, I promise. We'll give you the first exam too. And this is the exam from the pulmonary clinic, which was really notable for the diminished breath sounds at the left lung base. Otherwise fairly unremarkable, and vitals are here and pretty unremarkable.
Yeah. Okay.
We'll give you initial lab work as well. And I'll let you sort of...
So her bicarb's low, which is interesting. I mean, it's only 21, 22. Let's see, her FOS is okay, glucose is okay. She's got a protein albumin. Where's her albumin here? So she doesn't have a protein gap. Her LFTs are okay. White cells look okay. Normal differential, so no eosinophils.
No eosinophils.
Okay. So, I mean, it's not that helpful other than she's a heavy woman. I mean, her BMI is...
It's 48.
48?
Yeah.
And you would expect her to have OSA, but her bicarb's only 20. So you'd expect it maybe to be higher than that as a compensatory mechanism for her nocturnal desaturation and CO2 retention during the day. Did they check a blood gas on her at all?
Not at this visit.
Okay, that's fine.
Yeah.
But I find that interesting. I don't think she's got an RTA, but there may be something else going on here. Her renal function, most of the time it's because of a renal abnormality, but her renal function looks okay. So we'll just sort of table that and put it aside as something that doesn't fit.
Okay. Okay. All right. So here we are. This is the choose your own adventure part. I know you've mentioned imaging.
Yeah, I mean, why don't we start with the room serologies? I mentioned those. We were going to check an ANA, a rheumatoid factor, an ANCA,
sure.
and then see if any of those come back positive.
Okay, so we'll start with the room.
Okay, so our ANA is 1 in 80 speckled, ANCA's negative, SED rate, CPR, CRP. Okay.
And I didn't put it on here, but I believe an RF was checked and was negative as well.
Okay, so they're not really leading us anywhere.
Yeah.
Okay. And then the next thing would be your chest X-ray.
Okay. So we do have a radiologist here with us. This is Dr. Adam Naylor. He's one of our cardiothoracic radiologists. And we will do the chest X-ray. And maybe we will circle back to the CT later. Okay, so we'll start with the chest X-ray.
All right, so frontal and lateral chest X-rays show small to moderate left pleural effusion with some streaky opacities in the peripheral left upper lung, which are likely reflective of atelectasis or scarring.
I guess it's not working. Okay, sorry.
All right, just to recap, there is a small to moderate left pleural effusion, some streaky opacities in the left upper lung, likely representing atelectasis or scarring, but the remainder of the lungs are clear. The right lung is clear. There's no right-sided pleural effusion. There's no pneumothorax, and the heart size is within normal limits.
So we can't say with certainty that there's not something else in there other than the effusion.
Correct. Yeah, it's always
mean,
difficult to assess for
yeah.
an underlying mass or pneumonia.
Right. Or an infarct or a sequestration or anything like that could be hiding back in there. And on the lateral film, it's hard to say, but clearly there's something that's opacifying the vertebral column as we go towards the basis. So, you know, looking at this, and we'll look at the CT scan. And she doesn't have clubbing?
There's no clubbing.
No clubbing, okay. And her nails are okay?
Mhm.
She doesn't have yellow nail syndrome, okay. Well, you know, let's see the CT because there is an effusion there, then we'll have to tap it. And one of the things that we might want to look for is chyle, just to make sure that she doesn't have a chylothorax there. So the CT does show, oh, I guess you're going to tell us.
All right, so yeah, the CT redemonstrates that there is in fact a small to moderate left pleural effusion. This is a non-contrast study, but within that, within that factor, there's no overt pleural thickening that can be identified on this exam. The lung windows CT on the right-hand side of your screen shows that there are some, streaky opacities which converge on the pleura in keeping with areas of rounded atelectasis. But there's no underlying consolidation. There's no bronchiectasis or cystic change. There are no pulmonary cysts or discrete nodules that are identified within the lung parenchyma itself. And there's no pneumothorax present. So, non-specific finding of a left pleural effusion that's present without clear evidence for an underlying pneumonia.
Okay, and you said that she had some round atelectasis.
She did, yeah, these streaky areas next to the pleura would suggest that there's a chronic, the
component.
The pleural abnormality is
and
chronic.
there's no calcification of the pleura.
No calcification in the pleura.
Okay, so the other thing that could potentially look this way would be if she had, mesothelioma that was progressing over time. Let's say her dad worked in the asbestos industry and he was coming home and, she was exposed to his clothing, during her teenage years, 10 years out, that could be a possibility here, but without the pleural plaquing, without calcification, that seems unlikely. So we're left with a pleural effusion and she's got some round atelectasis here. Really non-specific, but the effusion is something that we probably need to think about going after and tapping. And just so I can ask, did you get cuts below the diaphragm? Did the pancreas look okay? Or
yeah, the upper abdomen looked normal.
okay, so no pancreatic lesions, nothing in her liver. Okay.
No.
Okay. So again, and no cystic abnormalities in her lung.
Correct. No pulmonary cysts were seen.
Okay.
I will say I cropped out some of the right lung here. There were a few small pulmonary nodules on the right-hand side, which were calcified. Some of them had a branching morphology that may suggest TPO or, that they were the sequelae of prior aspiration or infection. But again, it was a minor finding and a relatively, and suggestive of a chronic finding.
So we can pretty safely rule out LAM as a cause of hemoptysis. I think eosinophilic granuloma is probably unlikely in this woman as well, and this was a high-res CT?
This, I believe, was just a standard CT.
Standard CT scan. But again, even with the standard CT, she didn't have nodules that would suggest that she had eosinophilic granuloma, and there's no cystic disease at this point. So, and she's having hemoptysis. And the other thing that we want to check is just to make sure that the visualized airways are intact.
Yes, yeah, no endobronchial lesions were seen,
okay.
and there was no bronchiectasis by CT.
So what do we do next? I mean, this lady's got recurrent hemoptysis. I think I would still get pulmonary function studies on her, which may just show a little bit of a restrictive abnormality given her body habitus.
That's exactly what I'll just tell you. That's exactly
so
what it
we
was.
got that. And then the next step at that point, I think, would be to tap the effusion and to do a bronchoscopy. Just to make sure there's not an endobronchial lesion that's hidden. I mean, what kind of endobronchial lesion could she have that we're missing on a CT scan? Again, more likely a benign tumor of some type that could also be contributing to the effusion on this side, a carcinoid, an epidermoid tumor, something along those lines. And we want to do the thoracentesis and really make sure that there's no malignancy there. Send off for cytology. We might want to send off an amylase just to check that and make sure that it's not chylous. I don't think it's going to be chyle. I'm having a hard time putting a chylous effusion together with the hemoptysis without anything going on in her airway. But I think those would be the next two things I would do.
Okay.
I'm a little bit at a loss for a unifying diagnosis right now, but
Since you mentioned this earlier too, I'll tell you. So RVP was negative. She did get HIV, Hep B, Hep C that were all negative. I don't think immunoglobulins were ever checked, to be honest.
okay, so that's fine. That's
Yeah. And then blood cultures were sent at that previous ED visit that were negative. And so you mentioned
A
thora.
pleural tap. Okay, so she had a pleural tap. It was turbid, some red cells. They had 100 cells. She had lymphocytes there, 32. EOs were a little elevated. Monos were 50. Okay, and the max were 2. So it's not normal. I mean, you'd expect her to have primarily just have, macrophage and that. And her protein is elevated and her LDH is high relative to her serum, I guess. Her protein in her serum was
7.3.
7.3, so it's above 50%. So she's got an exudative effusion. Okay, and she's got lymphocytes there too. So 32 out of 100. So she's got some lymphocyte predominance. She's also got some monos there. I'd still get the cytology on her, but now we're sort of thinking about, what could be accounting for this. And was her triglyceride level checked?
It was not checked on this. No.
Did it look
It did not look
lipemic?
chylous at all.
It didn't look chylous at all? Okay, okay. And so I'd get a cytology on this just to make sure, and did we do a cytology?
Yeah, it's negative for malignancy.
Okay, all right.
Anything else you might be looking for on cytology?
Well, I mean, given her pleural fluid now, and this is where if I had done pulmonary for the last 30 years, it would be helpful. But thinking about what else could be going on in her pleural space that could be accounting for this in her hemoptysis, it's got to be an inflammatory disorder of some type. So we know she doesn't have lupus. We're not going to go looking for abnormal cells there. She's got lymphocytes there. So we probably should at least think about the possibility of an infection. We might want to culture this for AFB, for fungal organisms. It's unlikely she's got paragonnomyces. The rest of her CT looks fine, even though we have paragonnomyces here in Missouri. So all of that was negative. Okay. So she's got lymphocytes. Again, TB, malignancy, collagen vascular disorder. We've essentially ruled all those things out for the most part. So I would still next do a bronchoscopy just to make sure her airways are clear and do a BAL to see what the BAL shows.
Okay. So she does get a bronch, and essentially no mass or notable findings there, a little bit of hyperemia throughout the airway, but that was essentially it.
Okay. Did they do a BAL?
I don't believe so.
They didn't do a BAL. Okay. So now where do we go with this? We don't think she's got the sequestration based on the CT and the findings right now. Did they check an amylase in the fluid?
Yeah, it was normal.
Normal. Okay. All right. We don't think she's got any kind of a fistulous tract there. So what else is causing this effusion and accounting for hemoptysis, where she's got nothing in her lung parenchyma? It could just be episodic hemoptysis, but so why is she having that? Okay, well, since you have cardiology there, why don't we look at an echo?
I don't think it's going to be helpful, unfortunately. EKG is normal.
It'll buy me some time.
Yeah. And the echo is unremarkable.
Okay, so that bought me about 6 seconds. Okay. Okay.
Yeah.
All right. Has she had hemoptysis in the hospital?
So not in she's never needed to be hospitalized for this.
Okay, so outpatient. Okay.
Yeah. And I'll say, so after this visit, you sort of follow up with her, you go over the results of the pleura or of the thora. And she mentions her kind of hemoptysis has come back and her abdominal pain is happening at the same time.
Okay, so she's having abdominal pain and hemoptysis. She's had a CT of the abdomen?
Yeah, and it's
unremarkable.
Yeah.
Okay, and she doesn't have any type of mesenteric inflammation? So, okay, so Christian Weber disorder, Christian Weber disorder, I've only seen it once, maybe twice. I mean, where they have a paniculitis, she's a heavy lady and they can develop pleural effusions and hemoptysis, nothing like that. Okay. So,
That would have been really mean.
well, that, okay. Okay, so what else does she have here with the abdominal pain? Okay, let's think about this for a second here.
And maybe I'll give you one more thing. So you find the X-ray from that ED visit.
Yeah.
And the pneumothorax was real.
So she had a real pneumothorax back then. Yeah, so what's going to give you a pneumothorax repetitively here with the pleural effusion? I mean, a pneumothorax in and of itself can cause abnormalities in the pleural space, but the pneumothorax has to be related to something going on in her lung. And her lung looks pretty normal, except for the, what we think is round atelectasis here. And she's got the effusions. So what type of lung disorder could she have giving her recurrent pneumothoraces? If it's not LAM, she doesn't have interstitial lung disease. She doesn't have sarcoidosis or cystic fibrosis, based on the CT at least. Okay. She doesn't have a chylous effusion. Okay. Okay. What's that?
It does have.
Okay, there you go.
Does have a little bit of a correlation.
Okay, there we go. There's the answer. So, so she's basically got endometriosis. Yeah. Okay.
So on the path, they did
she's got
also stain her cells for ER and PR.
Yeah. So she's got endometriosis.
Yeah.
Yeah, there you go. Okay.
Yeah.
Well, I missed the endometriosis. So, yeah.
So, okay, let's give Dr. Kollef, you went through an amazing differential. I think part of why
next time, give me an ICU case.
So part of why this was so difficult is this is not by any means a classic presentation of this. The most notable thing, and this is actually what we were talking about beforehand, is that this is presenting on the left side, and these classically, especially with the pneumothorax, 90% of them present on the right. So I think that was a huge red herring to start with. But going over this patient's clinical course, so her pulmonologist was worried and kind of did decipher this cyclic nature to the hemoptysis. Touched base with her OBGYN, who was actually following her for sort of a PCOS eval that hadn't been diagnosed yet. And they kind of reached the conclusion that this likely was endometriosis. She was started on birth control with improvement in her abdominal symptoms and also her hemoptysis. She is awaiting an X-lab for a tissue diagnosis of intra-abdominal endometriosis. This is a very hard thing to diagnose, as we just saw. So there are actually different sort of levels to the diagnostics classification of thoracic endometriosis. If it's true thoracic endometriosis, we have tissue demonstrating intrathoracic tissue with hormone positivity and histology suggestive of stroma and glands. They're sort of probable when you have maybe one of those two, but not the full glandularity or hormone positivity. And then there's what's called thoracic endometriosis syndrome, which is actually more where this patient would fall, in that there's no true tissue confirmation, but has a very suggestive clinical presentation. To go over like the classic presentation, so like I mentioned, pneumothorax is the primary presentation, and it's typically 70% of the cases present first with a pneumothorax. The next would be hemothorax, then hemoptysis alone, and some of these cases do have pulmonary nodules. I wanted to show this picture because I think it's interesting. This contributes to why it's so difficult to diagnose, is the imaging can vary with the menstrual cycle as well. So these two images are 2 weeks apart, and this is somebody actively menstruating and then outside of their cycle. And like I mentioned, over 90% are right-sided. It actually becomes less right side predominant as you go down to hemothorax and then hemoptysis. And actually the hemoptysis predominant patients, like 25% of them can be left-sided to start. And then in difficult to diagnose cases, MRI, bronch, thoracotomy can all be used to try to get tissue. And then as far as management, it varies pretty significantly depending on whether it's a pneumothorax patient, a hemothorax, or what have you. But for recurrent pneumothorax, blebectomy, pleurodesis, and diaphragmatic repair can all be performed if needed. Sometimes the endometrial implants are resected, particularly if they don't resolve with hormone therapy over 6 to 12 months. And recurrence is actually quite common, even in the patients that receive surgical intervention. So it's definitely an area of ongoing exploration, and there are some new medications, hormone-driven medications that are being used to try to address this. Thank you for your time. Thank you all for coming. Let's give Dr. Kollef another hand.